Well, I'm thrilled to be here. I've only recently become involved in the World Federation, and it has been just a very powerful experience for me to learn so much from providers outside of the United States and to have that exposure. These are my disclosures, and some of the things that I do discuss today will be off-label for FDA-approved devices. We are all quite familiar with acute aortic pathologies, be it intramural hematoma, aortic dissections, or blunt traumatic aortic injury. Some of these can be quite easy to treat and very straightforward, but many of us know that acute aortic dissection specifically can be quite challenging, and the patients usually present incredibly ill. In the United States, the only currently approved FDA device is the gored thoracic branch device. And so most of what I talk about today from my perspective of the United States will be about this device. But at the end, I have some expansion on other devices that are coming out and where I think we need to go. So if we talk about type B aortic dissections and we look at branched or preservation of the subclavian artery, when we're thinking about preventing stroke and when we think about preventing spinal cord ischemia, this recent meta-analysis showed that coverage of the subclavian did not necessarily increase your risk for stroke or spinal cord ischemia. But there were also other studies, and this was one that was presented at the JVS Online Journal Club that we do each month. This was published in 2022, and I distinctly remember Jean coming on and discussing it with us. And really what he talked about is landing in a more proximal area is preferred for thoracic endovascular repair whenever you're doing type B aortic dissections, because when you are landing in zone 3, there was a higher number, which you see on the left, of reinterventions. And then, of course, there was decreased freedom from aortic-related adverse events and mortality whenever you landed in a more proximal zone. So I brought a couple of cases that are always fun and challenging. And this is a patient who has had a previous ascending aortic repair. And he presents with what looks like a fairly severe type B aortic dissection, or we could go all into the new classification and the 1 and the C and all those things, but I'm going to just leave it at this for right now. But you can see that the lumen, as you go down into the abdominal section, has 3 different areas. And so this was something that when he presented with malperfusion, there were a lot of challenges on how to manage this. And our cardiothoracic surgeons were not excited about going back into his chest or any type of treatment in that way, and asked us to really consider what we could do in terms of endovascular repair. And we used the Gore thoracic branch device, and we put a 45 device because he had that's distally what we needed. And in these dissections, you can use the petticoat device by Cook, but the radial force in those devices is very limited. And we found that here, he had already had a carotid and a carotid subclavian bypass. We did that initially and then placed the branch device. Whenever we placed the petticoat device and it didn't expand, we went ahead and then put in a second device, which got him out of trouble. And he went on to, yes, require abdominal resection of portion of his bowel, but did very well and left the hospital and survived. And this is his CT scan afterwards. And having the ability to do this type of treatment whenever you have these patients is important. And it's taken a lot of work with our industry colleagues to have these devices readily available for us on the shelf or brought in at any time of the day or night. I want to switch now to trauma, because trauma is something at our institution that is very prominent. So we are the busiest level 1 trauma center in inland California, and we see quite a few blunt aortic injuries of multitude of different of grades. And we have patients that come even from other vascular surgeons in places where they can do thoracic endovascular repair to our facility. And you can see here in this paper that was published out of Rochester, where looking at left subclavian involvement, if they covered it versus they did not cover it, the rates of spinal cord ischemia were higher whenever they covered the left subclavian in trauma. The total procedure time was, of course, longer, and then renal ischemia was longer. And so trying to preserve the left subclavian artery is important, even in traumatic injuries. And before the branch device came out, you can see here this particular severe blunt blunt traumatic aortic injury. And it's quite close to the left subclavian. And before we had the branch device, you had one. Your options were you cover it, or you just get really close and you hope that that works. And I tend to be a woman who says, I can get really close. I know how to deploy this device. I got this. And that's what I did. So I went in and I deployed that device, and it just sort of slipped a little bit while I was deploying it. And I thought, oh, I think it's okay. You could see screen right. It looks like it's sealed and everything looks okay. But when it came back a month and a half later, and this is a 22-year-old young man, you can see there just a little bit of it, and it's hard to see, but there's still filling of that pseudoaneurysm. And this is a case where, had we had the branched device available, we really should have used it at this time. And I realize it adds cost and it adds time. And many people have argued with us about, well, using that device, it's nearly double the cost. But in this case, I had to go back and put a second device. And this patient, we ended up covering his left subclavian because he did not want to undergo a carotid subclavian bypass at the time. Again, at 22, it's hard to make these decisions. And he ultimately developed arm claudication and ultimately needed surgery. And these are complex decisions to be made. So we have a paper that just came out in the Journal of JVS CIT, looking at our outcomes and our early experience with this thoracic branch device. And we have about 20 patients in this cohort. You can sort of see what the indication was, but we've had very good results with this. And building a relationship with partners that can bring these devices in and be available for you is really important. We're expanding this. We have a multi-center trial or multi-center registry that we've recently done and collected all that data to represent at this year's vascular annual meeting. But there are still emerging technologies that we really need to explore. In our facility, the ascending aorta is someplace that our cardiac surgeons sometimes do not want to treat and find it limited in their ability to treat because of previous surgery. So these technologies, the ASG by Gore, and then of course the Persevere, is something that I think are going to be interesting to see how they come out and how we use them as vascular providers. And then, of course, Arch technology. We've talked about the thoracic branch device by Gore. It's only approved right now in the United States for Zone 2, but the indication for more proximal is coming. We are in the EndoSpan trial. It's a very difficult trial to enroll in just because of the limitations. And then, of course, custom-made devices, which aren't necessarily available to everyone right now. So there are a wide array of devices that are under development in clinical trials, and there's a tremendous need for these in the acute area. I think preservation of the left subclavian artery is important in acute pathology, and in the next 2 to 10 years, I think we'll see a big change in what we're doing, and it'll be exciting. So thank you, and I appreciate the opportunity to speak.